Cool.
Yes, it is recording.
Yeah.
Sweet. I should be right here. Right here. We'll do this naturally. Any questions? Any questions? Anybody? No. So success is two ways. One is competence. So if you're completely incapable of being able to grasp any concepts in rehab, you're really out of luck. The only time that happens is when someone's really not interested, then they're not really paying attention, and then it really kind of shows, like, are you really interested? Because this happens to me. I mean, there's some stuff I don't care about, so no matter how many times I do, it doesn't work. The second part that can happen is just anxiety. I've had, residents and students, you just know they really care, they really want to try, they feel anxious, so they're not able to literally carry over. So the competence part, you can kind of know about yourself. I mean, if you are making games one day to the next, people will like you. That's one. The second part is your personality. You all have your own personality. So if you're passive and the person you're with is just super neurotic, they're going to say, oh, they don't seem to care, they're not like me. Versus someone who's super laid back and thinks they're the coolest person on earth, and you're very aggressive. Like, I'm very aggressive. That's how I was a student. Like, I want to do everything. They're going to say, oh my gosh, they're just really getting in my hairs. I hate them. So, and it just, how that goes. It's just like a reputation starts, and then you're like, yeah, I do think that. I think your best bet would be, the first couple of days, just keep it cool, all right? Keep it calm. Just saying, like, hey, if you need anything, I want to help, I can help. And then really look for someone who you really identify with. Don't just force yourself onto somebody. If you feel like there's someone that really kind of speaks to you as, you're like, this is the kind of resident I want to be, work with them. Because I'm sure they see the same in you. And then you can be yourself. So you can be as aggressive or passive or whatever in between that you can be. The things that residents will complain the most about is, oh man, the student was super annoying for whatever reason. I cannot give you a list of stuff. The student was, but conversely, if a student is very helpful, they'll say, oh my gosh, the student did all this stuff, blah, 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 blah. So that's the easy way to be successful. You want really a lot of face-to-face time. So if you can spend time with the attendings, that would be ideal. Spend time with attendings who you want a letter of recommendation from. So if it's the chairman or the program director, that's going to take you far. Really try your best with that. I mean, if a program director knows you and they spend time with you, they'll be able to write a really nice letter of rec. For the most part, people will just say yes to you in terms of writing a letter of rec. It just takes forever to get it through. You just really want something that's good quality. But there's no really rhyme or reason to success. I really believe that, because you go on a rotation. Let's say you really have your heart set on a program in Seattle, and you go there and you just do a bad job. But that may not be just you. It may be because you just aren't a good fit there. And then and that's life, And then you go some other place and you fit, and that's where it goes. So I would do not even overthink it. Be yourself. Go there 4 weeks. Try as hard as you can. If it works out, it works out. If it doesn't, well, you should say, I'm talented enough, I can go anywhere else. That's the point. So, and learn your mistakes. I mean, trust me. I'm sure when I was a student, I did some bad rotations, right? But you learn and you move on and you make the mistakes then. So when I went to my rush rotation, I put all my eggs into my rush rotation basket. Spent all my time with Dr. Young, did research with this person, spent all my time with Dr. Nicola, and then I just opened and prayed out and get matched. But you guys are so much smarter than I am. So, any other questions? But here's the thing: when we do it next month, just your first week into your experience, we can just bring up those questions of how you're feeling about your performance. Because a lot of times it's just more reassurance. Don't feel bad that you got 9 out of the 10 questions wrong, because some of the questions might be, they're just there. So, yeah.
As far as getting letters from away rotation people, especially the rotations closer to September, does it matter as much? I mean, when do we need to have them? Should they be submitted with the application?
Yeah.
If possible, or is it okay if it's like a little bit later? How much should you hound them, as it gets closer?
No, well, yeah, that's also a tough thing. So, day one, go and be as nice as possible to the program coordinator. I mean, if you want to get her, don't be, once again, don't be someone you're not. Like, I'm not someone that gives cookies to people, but I'll just be like, hey, thank you. So, a genuine thank you. And some people are just like that. they're really good at schmoozing with the cookies and stuff like that. But I feel like you're gonna be both equally kind of, yeah, so if I'm fake, it's so easy to tell. But be nice to the program coordinator day one. And if you're nice to the program coordinator, then you can kind of talk to them about helping get those letters of rec. When you submit your application, just make sure there's at least one PM&R letter, and then you can start adding on more if you need it. I think the best bet is to have the complete application when you submit. So if there's someone you really want, within the first week, you're doing a good job, just being like, hey, I'm looking for a letter of rec, just let me know when you feel like I'm worthy of getting that letter of rec.
Okay.
But you're gonna do July, August, September. If you get one, that should be good enough, at least for your initial.
Right.
We look for at least one, but like 2 or 3, just it's more powerful that way.
Okay.
Yeah. And it's tougher, when you put in your applications, it's tougher to see where you've done your ways. So the more letters, it kind of helps bring up like, oh wow, like really wants to do PM&R. So a lot of times people, I don't know how much thought people put into actually looking at the nitty gritty of the letters of rec, but they do look at the name. So if it's Dr. Smith from wherever, you say, oh wow, they got a letter of rec. And then some people really look at every last detail. So, and here's the thing, but you don't. I mean, it's something that's obvious, but you don't realize it's mood. Like I could be just in a crappy mood, right? We're all in a crappy mood, and like, whatever. Okay, fine, get a letter of rec, or give them an interview, or crappy mood being like, I had a bad interview with a student just like this. Boom. And this is not meant to scare you. So don't overthink it. There's
Do
some
your best and move on.
Yeah, just do your best and kind of move on. And then as the process goes, if you're not getting a interview, then you can always email the program coordinator and then just saying like, hey, I didn't know if you knew, I got 2 other letters of rec and PM&R, let me just email it to you, here you go. Or I got my step 2 score, and I just, here's my proof that I'm really a good student and I did 20 points higher, here you go. Then they're gonna say, oh wow, okay, thanks for letting us know this information. So, yeah. It's fine, don't worry about it, kids are fine. First part. So, those audition electives just, knocked out of the park. No pressure. So this is going to be more interactive today. So here's the deal. When you do your inpatient rotation, there's going to be a consults section. So when you're doing consults, there's a unclear science to do in consults. And the reason why I say it's unclear consult is there's nothing specific in regards to get this angio, and this angio is this percentage occlusion, you've got to do X, Y, and Z. There's an art, there's a science, there's an opinion on it. I'm going to give you my opinion on it, but I'm also going to give you some semblance of a structure. So you can use the structure to then form your own opinion. But whatever opinion you get, you want to be able to support it, and that's where that structure comes in. Now, what kind of rehab recommendations can you make? So let's say that they consult you. What kind of rehab recs could you make? You are a PM&R physician. So in theory, it's a PM&R consult. So what kind of recs could you make?
Inpatient rehab.
Sure. What other?
Acute or subacute or.
Sure. What else?
You don't qualify.
What's that?
You don't qualify.
You don't qualify? Okay. You're very negative today.
I'm sorry.
Yeah.
PTOT.
You're like F you.
PTOT in the room, like with them, not an admission.
Sure. What else?
AFOs, walkers, canes.
Fantastic. So orthotics, DMEs. Okay, great. What else?
Spinal simulators.
Sure. I mean, we're not going to put that in bedside, but I think you're getting at pain control. So I agree. Pain control recs. What else?
Maybe it's more outpatient, but like steroid injections, things like that.
Sure. I mean, why not inpatient?
Sure.
What else? What are the things that I'm harping on? When we start looking at the case, we're trying to put everything together, but we're thinking about rehab issues here. So as a rehab physician, we are doctors of function. So we are giving recommendations for this patient to be optimally functional. One of the things is acute, subacute, home health therapy. But the other thing is, and use your example, let's say that this patient comes in who really doesn't have much going on, but they just really messed up their shoulder so they can't use their cane.
Mhm.
Functionally, we say, well, if we can just get the shoulder better, then we can achieve our rehab goals and help you get home. Boom, there you go. So when you're doing the rehab consult, you can take one of two options. One, you can just be a dispo jockey, which means acute, subacute, and that's it. Or you can do a true rehab recommendation, which means you can make comments on bowel program, bladder program, pain, spasticity, cog, psych, basically all of our rehab issues. And that's what we're trying to look at, because as you make your recommendations, you have to be thinking about those. You have to be thinking about fall risk. If you were to say someone should go home with home health therapy, should you be assessing their fall risk? Heck yeah. Should you be giving them goals? Yes, because you don't just say, just do your therapy all day. What's that going to get them? Could get them nowhere. And look at healthcare costs. If I said someone goes for 20 sessions of home health therapy, without direction, they can bill it all the way through. They can always find something. You have to do therapy with a purpose. But if you're not accomplishing anything, you shouldn't be doing it. If, like, for example, if you're here daydreaming the whole time, right? God bless you, thanks for coming. But you're not getting anywhere. You're just wasting your time. And perhaps you're wasting your money for that matter. So we always have to think about rehab goals. So, okay. The first part of this whole process to get rehab goals is you have to understand where the patient came from. So you have to understand their functional history. So on your sheet of paper, we have a description about gait, ADLs, and cognition. It is critically important that you understand what their functional history was. So if someone says that they're independent, what does that mean to you? They say they're independent, what does that mean? What's that?
Bathe, dress,
Sure.
go to the bathroom,
Yeah.
feed themselves.
What's that?
They may live alone.
Okay.
Not having any help from their at home, so they're independent, flexible.
Yeah. And here's the thing, there's FIM scores that we talked about, right? So conceptually, if someone says they're independent, what's their FIM score? You guys remember, the FIM scores were 7 is complete independence, 6 is mod-I, which means that there's a modification, meaning there's a rolling walker. 5 is supervision, and 4 is min assist. 3, 2, 1. So if they say that they are functionally independent, what does that mean?
They're a 7 is one.
That's what they claim. Now, let's say that they're saying this is their perception of where they're at. So they're claiming to be independent. They might have had a stroke, a TBI, a spinal cord injury. If a therapist would have looked at them at home, is it possible that a therapist could have said, you're actually their min assist for gait? Yes. They just say, I'm independent. I do everything I need to do. But if I were to FIM them, this is what's happening. So you could really go down the wrong path, looking at the comorbid condition, saying, oh, they're independent now, and then, oh my gosh, therapy is just saying they're min assist, they can't go home now. And you talk to them and say, no, I'm the same. Everyone's told me this. I have a foot drop. I have to wear this. It's not perfect, but this is what I do. I fall 1 time a week, 1 time a month, and I accept the responsibilities of the fact that I fall once a month, and this is where I want to be. So when you ask the question, you really want to scrutinize what's actually happening. So they might say, I'm independent. What does that mean? 1, are they lying? 2, is it possible that cognitively they may be thinking about a time 2 to 3 years ago? Sure. So you really have to kind of use your judgment. Do I need to call family? Do I need to talk to the people at bedside? Or do I really don't put too much credence to what they're saying right now? So, gait. What do we want to know about that gait? They're saying, I'm independent. I'm walking around.
I want to know about like how far they can walk without maybe getting tired, things like balance, stuff like that.
Absolutely. How far can you actually walk? Someone says, I can walk independently for 5 feet. Well, that's a short distance. I can walk a long distance, and then the main question is, what stops you from walking farther? What are things that can stop people from walking farther?
Pain.
Pain, great. And if they say pain, you're going to ask the next question is,
That's
where is this pain? Yeah? Because maybe I just have bad knee pain. I've never gotten an injection. Well, here you go. Now you're walking 300 feet, whatever. So it could be pain. What other stuff? Strength? Okay, what other stuff?
Target, shortness of breath, CHF type thing.
Absolutely. So, now that you say that, are comorbid conditions very important? Yes. Look at those comorbid conditions and with your medical knowledge, you're going to try your best to extrapolate what is the actual impact of it. You can ask them, like, hey, looks like you had a heart attack about 6 months ago. What's been the impact of it? Well, I've been more short of breath since that time. They told me my heart has issues. Oh, your EF is 25, and you're not great about taking your meds, or you're always fluid overloaded. What about the liver patient? The liver patient that has, they're getting end-stage liver failure. They come in for these hospitalizations. It's fluid overloaded, hepatic encephalopathy, ascites, treatment, or treatment and then get better, whichever way. It's kind of an up and down. So you got to capture that story. But what's the main thing people might say? Let's say that they said, I had a heart attack six months ago. There's a functional history for the past 6 months, and what's critically important?
Where were they before that?
Where were they before that? And then you have to think, can we get them back there? Because they might have said, well, I've been having nagging knee pain for the past 6 months, and before this I was running marathons or something. I'm just giving you something extreme. Now you're saying, well, the only thing that's going on is this knee pain, and I think it's arthritis. I want to give you a treatment plan so I can get you back to where you were. Versus someone that says, completely plegic on one side, even though I was independent 6 months ago. Well, we're not going to get you back there. We have to get more of a realistic goal. Now, what about gait mechanics? What do you want to know about gait mechanics? Someone had mentioned, you said balance issues. So what do you want to know about that?
Well, have you had any history of fall? Then that's one thing I definitely have to ask patients.
Yeah.
And if they did have falls,
Yeah.
how many times and what caused the falls.
Absolutely. And you want to get a general impression. They might say, oh, it's bad luck.
Yeah.
Bad luck can happen if you're not using your cane. So if they say that, I use a cane, they have a fall, where you use that cane, what's happening? What about foot placement do you want to know? Just from a fall perspective.
Is it like a wide-based stance?
Sure.
Is one foot impeding the other? Is there proprioception off where that
Yeah.
they're constantly running into the other foot, causing them to fall?
Absolutely. What I typically do, you can always do the, hey, is it like you're drinking a couple of cocktails but you're really not? Is that what people are telling you? Or do you feel, or I just tell them, look, can you describe your gait? And I'm like, hey, let me just show you. I'm like, no, don't, and we can always see it and we can assess it, but we want to know their perception of it. So say, no, if you were telling me over the phone, how would you describe your gait? They can say, well, it looks like, I put my foot down, I just think I don't know where it is, or going up the stairs, I always knock it into the stair. And for spasticity, the way that I like to describe it, because spasticity is hard for people to describe, because they'll say, oh, it's stiff, it's this, and I'm like, if you're in this much of water, right, like everyone's been at the beach, and someone's calling out your name, you're going, but your body's going in front of you, and your legs are just really giving you resistance, that's really worked well. People are like, yes, that's exactly what I have. So when you talk about spasticity, you can talk about your foot crossing over. Is your foot dragging? And then you can tell them, is it dragging? They're like, I don't know. I'm like, let me see your shoes. If you've got scuffed up shoes, that's a problem. One of my patients has got new shoes every week. So it was like, because I tell him, like, scuffed shoes. Like, no, it's like, I'm fine. I was like, but I'm like, I've seen the way you walk. There's no way. But new shoes every week. So now, ADLs. What are ADLs? Just for generic perspective.
Bathing?
Bathing. What else?
Dressing.
Okay. What else?
Eating?
Eating. List goes on. Just activities of daily living. What do you want to know about it? What's a question you want to ask? Let's say we talk about dressing. What questions do you want to ask?
Are you able to dress in the pathway?
Sure.
How long does it take you?
Great time. Huge. What else do you want to know?
Are there certain clothes you can't wear, like if there's buttons or zippers?
Absolutely. So yeah, I clothe all by myself. I take 3 hours and I wear sweatpants all the time. Nothing wrong with that. We see if that's what they want to do because they say this is what helps me maintain my independence. Fantastic. But we want to ask these questions. What else do you want to know about? Let's say I'm doing all my dressing like this. Am I standing, sitting? Where is my positioning when I do this? Smart choices help prevent falls. So if they're saying, well, when I do my bathing, I always stand in the shower. And I'm saying, well, do you have grab bars? Nope. You typically use your walker, so how do you stand up? Well, I just kind of hold on to different parts of the wall. Well, that's very unsafe. Maybe a shower chair would be helpful. So just ask them about how they're doing it. And then we talked about time. And then we have to also ask them about this. How do they feel about the way that they're walking, and how do they feel about the way that they're doing their ADLs? If they are pleased with the progress they're making, leave it alone. Unless we think there's a fall risk that's kind of inherent there. Then we have to kind of chime in. but be respectful of that patient's independence. You don't want to be like, oh my gosh, why would you do that? So, cognition. How do you want to get cog? How do we want to assess cog? And this is just you talking to the patient. I thought you were opening your mouth to assess it. No.
I'm a messy.
What's that?
I'm a messy.
But this is an interview with the patient. So what questions do you want to ask that
What's the
patient?
date today?
What's that?
What's the date?
Oh, no.
Oh.
That's not part of the assessment. We're asking them how they feel about their cognition.
Are you able to pay your bills?
Right. Sure. What else?
They feel forgetful or having memory problems, or you can ask family to people around them.
Absolutely. And be respectful. There's a two-way street you can look at this. So if someone has a disability, you want to you don't want to just have the conversation with family, because then it's very disrespectful. So you want to have that conversation first. And what I usually do is, look, this is, it's a standard process. You're giving me a lot of great answers. Do you mind if I ask your family about this cognitive part? Because I feel like they'd tell on you better than you would be admitted, right? You can just disarm them with a little bit of honesty, a little bit of a joke. Then you can ask the family, what would kind of question the patient's cognitive abilities? What kind of things in the chart?
Taking medications on time.
Sure, yeah, absolutely. It's like the 10th admission for not taking meds. Whoa, there's something going on here. Could be social, could be psych, could be cultural, could be cog. What else?
Did you misplace your keys or
Yeah.
lose something you can't find them?
Sure. What else?
If they're getting lost in a familiar place.
Absolutely. And the other thing you can do, just simply looking at the chart, look at the comorbidities. If there's a history of multiple strokes, or there's a history of, you can just look at a CT scan and be like, well, this is showing a lot of vascular changes, like, maybe I should ask that question. But look at it conversely. There's a lot of people that will put in dementia in the chart. Well, that doesn't mean anything. There's like early onset dementia, or showing signs of, that really doesn't really assess if they're really able to care for themselves, or they're independent or not independent. So scrutinize that both ways. So you can ask them the question like, hey, when did you have a stroke? I had 2 years ago. What happened? I had facial droop, but I've been good since that time. Family says, yeah, it's been we've been very thankful that nothing's happened about it. So, and definitely scrutinize that dementia, because look, your unconscious bias can negatively play into this whole process of unnecessarily institutionalizing somebody, or unnecessarily not respecting someone appropriately. So make sure that you're aware of that, going with a kind of a clean set of mind. So you get the functional history. What do you want to do with SOCH? Because we talk about the function, we're just saying I walk like this is how I do my ADLs, this is how I walk, this is the number of falls that I have. And they're going to start cluing you in, wife, husband, brother, sister, son, helps me here and there. So what questions do you want to ask about SOCH? Where do you live? Okay. What's
How
that?
many steps to get into your
Sure.
house?
Okay. What else?
Who do you live with, and like if they're providing assistance to you 24 hours.
Sure.
Supervision.
And expand on that part. Are they able to? What other questions? I'm able to provide. I'm physically able to provide assist for my family. I'm just too selfish. I got my own stuff going on, right?
Yeah.
So what other questions? Expand on the family part of it.
And we want to check, the home where they're going back to, or wherever it is they're going back to.
Yeah.
If there's somebody there that can be watching them.
Sure.
24 hours of the day, just like a family or friend or somebody that even come to the house.
Yeah.
Maybe check on them.
What about playing to cultural kind of aspects to this? Because someone might be there
Yeah.
24 hours a day, if they're physically there. But
Okay.
what about culture? Let's say we're talking about culture, or men versus women, comfortability.
Yeah, so maybe are they, I guess, probably we get a little more specific and ask, are they willing, or would they be willing to help?
Yeah,
Based
absolutely.
on, whatever.
And you can kind of look at the chart. So let's say that someone has more, like really significant deficits, really needs assist with bathing and dressing. You have to ask them a question, do you feel comfortable going into the bathroom to provide that assist? They might say, that's not for me. Or culturally, I'm just not allowed to do that. Or culturally, we're not allowed to have a stranger come into the house to take care of this. What about asking the question, the physical ability to? A lot of people say, I can do it.
Yeah.
But then, do you have your own medical issues, or are you scheduled to leave? So, is your schedule malleable to allow this? The other thing you have to be careful of is how long can you provide that assist for? FMLA is only for a certain period of time, or they might say, well, I can take time off but at a certain point, I gotta go back to work. I have to make money, or we have to maintain our health insurance, whatever it might be. So you wanna know how long that they're there, and that's where your goal creation is important. You might say, 3 months, great. I'm gonna create goals where we can get to this level. If we got to this level in 3 months, is that good for you? They're gonna say, that'll be perfect for me. There you go. Or you might even say, look, I'm pretty certain this patient's safe to go home. You gotta give me a week. Just go home, stay with them for a week, make sure they're gonna be okay. Then we can make sure there's not gonna be a fall. Okay. What else do we want to know? Okay.
Like, are you able to report a caregiver once you go back to work for your family member?
So say that again.
Like if you have somebody taking care of like the injured or disabled family member and they have to go back to work, are you able to provide like a caregiver that you pay for or something like that?
Exactly, right. The financial aspect of it. What else do you want to know about the house? Or the social, sorry. The house in particular. We're talking about steps. So let's say they got 100 steps.
Elevator?
Yeah, is there some other option? What other things could you do?
Where the bedroom is,
Yeah.
bathroom, are they upstairs, downstairs, things like that.
Absolutely. And then, did you want to know, could you move down to the first floor if needed, or do you have the resources to get a ramp placed? If you're waiting for the city to do it, it takes about 6 to 12 months. You can always find a handyman to do one quickly, or you can get those temporary ones. Unfortunately, everything's driven by money. So if someone is well off, easy. But if someone, people that are underserved communities, it's much harder. So you have to be a lot more creative. And that's a big thing. I think we just had one of our residents did a great, nice talk about health disparities. So you really have to put in equal effort to people that come from more underserved communities. And you can't just say, well, no, you have to go to a subacute facility. That's the antithesis of what we do as rehab physicians. We have to give them every creative options to help them achieve where they want to go. They might even tell you, look, I don't care what you say, I want to go to this rehab place, I've been there before, I really like the people there, I'm going to get better, and then I'm going to go home. Fine. But you can't just say, nope, sorry, because you don't have money, you got to go to a subacute facility for the next several months. It's ridiculous, right? So there are creative options that may not be the best options, but it may be a really nice option as long as they understand the risk benefits of it. So that's besides the point, or that's very important, but I'm getting away from my questions here. So we talked about the house, we talked about the location, talked about the people there, the willingness to help. What are the things that we want to know? Socially.
Their goals, if they want to be active in the community, or if they want to work or volunteer.
Sure, but it's not their want to.
Well, like, yeah, but like if first
No,
assessing if that's something they're interested in, and then
Yeah.
if they can, and how you can work together to.
Yeah, no, I'm not. Oh no, I'm not dismissing you. No, that's more the goals end, right?
Yeah.
But right now, it's do I have to? I have to work. I have a big. I don't care what you say. I need to get back to work in 2 weeks because I have a big project. Or my boss is, gonna fire me if I miss a day, and that could come from not the patient, but the patient's family member who are asking to provide assist. What other stuff?
Substance use abuse in both the patient and then the family members as well. I think when we touch on the family members, you're also kind of touching on reliability. It's like, okay, is someone going to be helpful here, but then they're going to be strung out every night at the same time, and they're not going to be helpful in caring for this patient.
Absolutely, and that's going to be a challenging one. You can't be like,
Yeah.
So that's a challenge. What about the?
To kind of touch on what Austin just said, like, do you feel safe at home?
Sure, absolutely. What else?
Level of education
Mhm.
and what their occupation was before.
Yeah, absolutely. So we talked about the return to work goals, absolutely, and then the way that we approach them with different information. So if healthcare, if they're not able to comprehend some of the stuff that we're saying, we might need to approach it in a different kind of way, especially with the family members as well. Because trust me, the worst things that we do as physicians is just it's like we did like a fantastic job 95% of the time that they're there. Amazing job, we just saved their life. Then the last 2 seconds is like, here you go, here's your sheets of paper, get out of here. And that can really undermine the patient's success if you don't really, if they're not understanding everything that's going on. What about driving? Yeah, just make sure you ask them about driving as well, huge. And then of course, you can ask them about DV and orthotics. There's a little bit of redundancy because you would have kind of figured out all this stuff, but you might even ask them the question, you have a shower chair, why don't you use it? I see that all the time, like, you have 10 rolling walkers, you don't use them, oh, they're all messed up, or I've lost all of them, so. So, let's pull up this sheet here. And this is the one that you have to take a little bit of leap of faith here, it's gonna be a little bit of a challenge here. But remember, if there's one thing you take away is that the decision for acute rehab and not acute rehab is an opinion, okay? It is an opinion. My residents all the time being like, man, you know, I just gave this rank and I worked really hard at it and then you just overruled me and I look silly and everyone thinks I'm not a smart guy. No, it's not that. It's just my opinion. I'm in a position of power so I can make whatever decision I want to make, right? And it's not like they're wrong and I'm right, but the thought process is important because as we go through this chart, you'll see if I weigh things differently than my resident, then my conclusion is completely different. And we talk about it all the time. You're wasting. So this is what we're going to do. This is a chart. There's acute rehab on the top, you guys can see, and there's subacute on the bottom, and there's home. What we're trying to do is use it as a tilt table, okay? So if the whole process tilts up, where are you going? Okay. If you're tilting back down, where are you going? And if you go to the right, home with some sort of home service of some sort. So the first thing you are looking at is prior level of function. We talked about that in a second. Where were you at? How are you doing? Do not FIM it. Do not ever FIM a prior level of function. You're only getting the description of what the patient is doing. What I do in my notes is sometimes say, patient was independent but was limited or is a effective min-assist level. Okay, but you want to be careful not to FIM it because that it's very misleading because you might write accidentally mod-I before, but in theory, they're a min-assist. So you can say, does that, you guys all, you with me on that? No? Okay, so the FIM scores are only intended for the therapist to assess a patient. A patient might say that they're independent. So the patient's description is that they're a 7. But if a therapist were to see them, they'd say, no, they're not, they're at a min-assist level. So don't use the FIM scores when you're describing the patient's description of their past high level of function. What you can write is, patient claims to be independent but was limited for these 10 reasons. So I just put, sometimes for the residents, say, look, it seems like they're describing themselves more at a, min-assist, more of a mod-assist, even though they were independent. Okay? So what do you want to give? Current functional status. Who's going to give you that? Is that? PTOT is going to do the best job of that. And you yourself, can you do a functional exam if you wanted to? Heck yeah. Get your hands on the patient, get them out of bed. When you're medical students, we're going to try to create opportunities for you guys to work with a therapist so you can learn how to do a functional exam. Because that's critically important for your job as a student. But as a student, do not get someone out of bed without a resident or attending or anybody else. You will get into trouble, please don't do that. But current functional status. So when therapy does their evaluations, what are they going to do? How are they going to assess that patient? What are they looking out for? What is PT looking out for? What's that?
Motor and neuro.
Yeah. And they're going to equate it into what? FIM scores, right? They're going to give you, this is where their assessment is. What else do you want to look out for in their note? What else could they comment about?
Cognition, understanding,
Sure.
tasks.
Absolutely. What else?
Motivation.
Motivation. What else?
Social support.
So yeah, absolutely. Like you could have spent an hour. You got the patient has cognitive issues, and you got the wrong information, right? This happens all the time. They're like, "What are you talking about? Like, what are you saying?" No, they're like, "I talked to the wife. You got all the wrong information." Okay. Yeah. Could they comment about all of the rehab issues? Hey, patient was pooping on themselves or peeing on themselves. Their pain was through the roof. Now remember, are they capturing a moment in time? Yes, they are capturing moments in time. And it'll be obvious on there, saying like, look, I tried my best with this session, but the patient just went through dialysis. And I'll come saying, do you think this is the best representation of the patient? Like, no, you're like, you couldn't get a good evaluation. Okay, helps you understand. It'll say that on there. So it's a moment in time. Okay. What about OT? What can OT kind of look at from a generic perspective? PT is doing more of gait assessment, and I'm generalizing this, so they're watching on TV, right?
Upper extremity stuff, thinking, are they able to feed themselves,
Sure.
able to clothe themselves, bathing, things like that, more activities of daily living as opposed to primarily like gait-based and strength.
Absolutely. And the occupational therapist can comment about it, saying, I saw them walk, in their narrative, they can say, I saw them walking to and from. So Just look at ADLs, right? PT can do the gait for the most part, OT can do the ADLs. OT will talk a lot about cog based off of the testing that they do. But they both can have a little bit of overlap in terms of kind of saying, look, I agree that the cognitive deficits are really bad. They're not carrying over, and OT says, yep, I see the same. Or they could disagree, saying, yeah, when we strategize it this way, this was better. Okay, so we want to look at both of them and look at all those FIM scores. So you'll know what their prior level of function is, and then they're going to have their current functional status.
Yeah. I got a quick question for you. So where does speech path play a role in terms of like PT, OT, like cognition? When I've dealt with speech path in the past, they've primarily been the ones doing more like cog testing and things like that.
So in an acute inpatient rehab setting, obviously speech is going to take a pretty big role in cognition. With functional cognitive treatment and assessment, and OT is going to help out with that. In the acute rehab setting, the reason why I've not included speech, not it's a disrespect for speech, is that the acute medical side is not always ordering speech, and we can't always wait for speech, because I would love for it to be like, we can't make a decision without that speech evaluation. And not all patients need a speech evaluation. So speech is there, you really have to give them the primary respect when it comes to cog. So for the neural brain, the speech evaluation gets done. But remember this, the team is looking to help move the patient. They're not worried about cog, because they can actually make a decision of, yeah, they're really ANO times 0. They're really looking for swallow. So sometimes speech has to come and say, are they safe to swallow or not? Do you have to peg or not? So yeah, put it in there. If you can get it, use that part of your assessment. And I'll change that too, because I think the speech therapist will kick my butt. So you want to look at positive factors and negative factors, okay? And so we're going to use the positive and negative factors to create goals and then see which way we're tilting, okay? If we stack up a lot of positive factors, where are we going? Acute. If we stack up a lot of negative factors, where are we going? Subacute. But before we make a decision, we have to do one thing, get goals created, realistic goals, okay? That was one of my favorite things with my first residents that I ever had. We would have fights every day, like, what are the goals? He's like, I don't care, they're going to acute rehab. But the goals are so important, otherwise you're really going to shortchange the patient. So, positive factors. What are the 2 positive factors that I wrote? Or just read them out, someone read them out.
Acute medical issues with expected recovery.
Okay, wait, let's look at that one. What is that? Give me an example of that. Acute medical issue with an expected recovery. What do you guys think?
They have something that happened recently, and you are pretty sure they're going to get better within a week.
Sure. Give me a diagnosis and an example.
See, Jeff is asking.
There you go. Perfect, right? They come in. They just had salt shakes all week, right? And they stopped their Lasix. So they're really overloaded, cannot breathe, stuck. They were stuck in the house for 2 weeks because of this. Now diuresem. They are going to get dramatically better, which means we're going to be able to achieve our goals a lot quickly and more realistically. I can be really aggressive with my goals. Fantastic. I agree with that. Or there's and you could even say with some of the strokes, if it's an acute stroke, it's not an expected recovery. We know there is going to be a recovery. Versus if they had a stroke that was 2 years ago, are we going to see major progress made? No. Okay. What about rehab issues related to a new neurologic process? Name me, what's my favorite 2 things? Somebody wants to pass this rotation. What am I always harping on as my residence for? Anybody? B and B, right? For example, you have a spinal cord injury or cervical myelopathy. There are rehab issues related to it that we expect we can treat. Neurogenic bowel, neurogenic bladder, what other stuff can we do for our rehab issues? Just name them out. Any rehab issue. Spasticity, yes. And we can say the spasticity is bad, but man, I know we can treat this well. What else?
Pain.
Pain, absolutely. Not chronic pain, but acute pain, absolutely. What else?
Energy.
Energy, great. Motivation, mood. Let's say someone just really had a stroke, and the psych team is seeing them. They're saying, this patient has really bad depression, but you can see, they're already making a little bit of adjustments, or they're really starting counseling. It's making a positive difference. We know this. It's not going to be so negative that they're not going to be able to progress. We're seeing something positive. We can make this better. Or you can just say that it's not getting better, but we really want to grab the bull by the horns and make it better for them. Because they're horribly depressed and they go home or to a subacute, what's gonna happen? They're gonna flounder, right? 60% rule. Did we talk about this? Look at the other sheets. And I put the 60% rule with, in this category because of this. So for a acute inpatient rehab center to be credentialed as an acute inpatient rehab center, 60% of the patients have to have those diagnoses there. 60%. Which means that Medicare, which kind of creates all these rules, says that these are diagnoses that they believe are the ones that benefit the most from intensive rehab acutely after it happens. So remember, the 60% rule is for acute injuries. You can't say you had a stroke, 10 years ago, we're gonna bring you to the rehab unit. It's the acute injury. So what are the ones you guys see on there? Brain.
Stroke.
Turn it over. You have to look at it. What would you guys think is the, would benefit from rehab? You guys glanced at it, so you guys can choose, but it's totally fine. What do you guys think would be good? Because you have to think like that judge that's going to be deciding all this when it goes to court. Should they have come to rehab or not? Conceptually, what do you guys think? What's up? And the hip and knee replacements, according to the 60% rule, and I think it's going to, orthopedics is going to unfortunately phase out as a primary diagnosis. No.
That's all there is at the VA, everyone on the acute has.
And the VA system is a little bit different, but regardless, hips and knees can only come to acute rehab or qualifying at the 60% diagnosis if they're age greater than 85 or BMI greater than 50. So think about someone who's very old, has sarcopenia, has really a lot of comorbidities, and it's going to take them a lot more intensity to recover. Or BMI greater than 50, there's a lot of just weight and biomechanics that you have to address. So orthopedics, go ahead.
I have a question regarding that. So typically with acute inpatient rehab, you're working them hard, 3 hours a day, things like that. How can someone who's either over 85 with all these comorbidities or BMI over 50 really, are they able to kind of do that 3 hours of acute inpatient rehab in terms of like a knee or hip?
Sure. It's a very, very good question. What do you think? Well, let's say that I just put the patient and you're like, what? Are you kidding me? I can't accept this patient, but I'm like, so
you just modify things, you modify the therapy to make sure that they're able to do it.
Think about the spinal cord patient. The spinal cord patient, when they work with PT, they're not working on gait. If they've had a complete spinal cord injury. The rule is that you have to create goals that are realistic goals that you can achieve with an intense 3 hours a day program that the patient can tolerate. So as long as the patient can meet each session, they're demonstrating that they're progressing from one unit to the next. It doesn't have to be gait, it could be transfers, it could be something else. And they're demonstrating their progress, you can make it work. Where it becomes fishy, and this let's look at the other end of it, where Medicare is going to be a lot more scrutinizing, they're saying, well, in theory, by virtue of what I said, I can make an argument for anything. You say, well, you busted your toe, well, you can make every session, I can make things appear as though you would benefit from it. So that's why they're starting to scrutinize, they're saying, really make your case. So if you have CHF, acute CHF exacerbation, we expect there to be an actual recovery versus your EF is 10%. Well, we don't expect that part to get better. You're going to be extremely limited. So it's a case-by-case basis. And this is what I'm saying. There's a lot of subjectivity to what I'm saying, and it's going to appear to be confusing, which is why we have the case examples to argue our case. As long as you can argue your case either way, you're fine. But someone in a position of power could decide otherwise. And so that's where it gets super confusing. So you really want to use, as best you can, use this to kind of build your case. That's all you're doing, okay? Now, the 60% rule, so we talked about orthopedics, those hips and those BMIs. What are the things you think would be like core rehab?
MS flare?
MS flare, good. Yeah, it's a neurologic thing. The judges that decide upon Medicare, they're really cool about the neurologic cases. So MS flare, a true MS flare. Pseudo-exacerbation, which is, if you have a UTI, they're not as understanding because the expectation is you're supposed to return back. Which I'm saying that way because everyone's experience is going to be different. But MS flare, okay.
Amputation.
Amputation, absolutely. What else?
Motor vehicle accident,
And-
depending on how bad they are.
Exactly. And so let's say that we had a motor vehicle accident. Just use that example. What kind of injuries could someone have if a motor vehicle accident and catches on fire?
Burns.
There's one. What else could happen?
TBIs.
TBI. What else could happen? What's that? Spinal cord injury. What else could happen? They have to get extracted from the car. What's that?
Broken bone.
Broken bones. And so it's major medical trauma. So it's major trauma that affects gait. Also, it causes damage as well. So that's one of the diagnoses. What else? If they have to be extra, if they're stuck in the car,
Amputation.
they might have to do an amputation. Okay. What else? If they're older and they really hit
Hip fracture.
hip fracture. Okay. What else?
Damaged internal organs.
Yeah, damage internal organs. So if you look at that sheet, you can actually turn it over. If you just look at just think about, if you're thinking about the 60% rule, just think about a car accident, because you can have a bleed and have a stroke. You can have a traumatic brain injury. Where can I find it? Yeah, yeah, spinal cord injury. The congenital deformity, of course, is PEDS patients. That doesn't apply to the car accident. Amputation, the multiple trauma, the fever, the burns, and so that gives you half of them. So some number, obviously, that question is think car accident, half of them, and then you have PEDS, and then just you can just look at whatever rotations they have listed, right? Neurologic disorders are here as well. So we talk about MS flare, has to be something new. If it's a polyneuropathy, so you can look at Guillain-Barré syndrome, the CIDP. Parkinson's is very difficult. In the olden days, Parkinson's was very easy to get people in. You really have to make a case of why they've had a sudden decline and why they should return back. Give me a scenario. What do you guys think? Of a scenario where a patient is hospitalized without, Parkinson's is a degenerative condition. So in theory, it's going to be a degenerative condition unless you do something silly and, So give me a scenario where you'd want to bring someone over to Parkinson's.
So kind of superposed dementia, that just kind of speeds up Parkinson's.
But then why would you bring them over to rehab? The argument they would
Still
say,
get a
well,
different-
yeah.
Maybe a new diagnosis and they respond really well to initial medication.
Sure, yeah, it's newly diagnosed, right? They've been falling 100 times and no one figured it out. Good, I'll take that.
Like a overlying medical problem, like the CHF or something like that.
Perfect. And it could be even subtle stuff that makes a big difference. So they get admitted for, not the worst CHF exacerbation. They just let's do 2 days, and they're like, yeah, we gave them one shot of Lasix, they're doing great. But your argument can be built on the meds have been missed for the past 3 days, so they're off, and their nutrition has been declined because of it, or they've been stuck in bed. Because we know that with Parkinson's, exercise increases dopamine in the brain, which is the primary reason why. So you link it to something, build that story, okay?
Cassie, what about something like a PE or DVT, and they've been kind of bedbound or someone's been in the hospital for a while?
It's more on them being bedbound. You can link it, you have to give them a reason. So they're bedbound because of PE, DVT. Still, it's difficult, and it's an argument, you just have to argue your case properly. Now I'm giving you the harder ones on purpose, because when it's a new stroke, straightforward. You're gonna be like, I know what to do. Okay. So yeah, Parkinson's, you just have to be on the careful end. And once again, here at Rush, we're trying to be as progressive as possible in terms of really scrutinizing the cases that come out of rehab, because Medicare is just slashing everybody. And so when you go to a different institution, they may not be as progressive. They might just say everyone can come over, but soon enough, you guys will realize that you can't do that. So anyways, but here's the other thing. The most important thing is that you create realistic goals. So if you think you really can create realistic goals that you can achieve in a certain period of time, it'll tell itself to you. And we'll show you examples. So.
The same applies to muscular dystrophy because that's a chronic thing.
Yeah, it's really tough with if the muscular dystrophies, it's going to be tougher with ALS, and I don't even know how they feel about ALS, because we don't, the volume of those patients usually get diagnosis in outpatient earlier and earlier with a lot of the awareness that we have.
So with Parkinson's patients, I know a lot of times you see gait instability and stuff like that. Is that, depending on severity, is that enough to consider somebody for an acute rehab, or is that
Not necessarily,
Okay.
because they're going to ask about, remember the word acute in acute rehab.
Yeah, okay, I see.
Yeah, they're going to say, well, no, they were at home.
I see.
So, and this is where the model's changing now. You can see the active RA, the ascovasculitis that's affecting all of the joints within the body, okay? So, let's come back to this part here. We've kind of talked about that 60% rule. Give us some thought process. we really want to say if it's a true 60% rule that's new, that meets that criteria, that's a positive factor. If they've had an old stroke, where would they go? What's that? No, not subacute. Negative factors. Don't think, the last thing, if there's one thing that you learn, I've said a lot of this, I feel like Barney. the one rule, it's like cognitive. Don't think about acute, subacute. Think about your positive and negative factors. If it's a really bad Parkinson's disease and it's old and there's nothing new, it's going to be more of a chronic medical issue. If it's a newly diagnosed Parkinson's, they're 60% rule. Or if you want to say CHF exacerbation with expected recovery in the setting of Parkinson's, positive factor, because we're saying I want to link it to Parkinson's, which is why their functional recovery is going to be different. Okay. Negative factors are chronic medical issues. What about poor cardiopulmonary function? Give me a scenario where cardiopulmonary function is poor. COPD, severe emphysema, or horrible heart failure, which is stable, but their EF is 15, right?
I have a question. If you have like a patient with Parkinson's or whatever, and they have a COPD exacerbation and they continue to smoke,
Okay.
do you send them to rehab?
Oh, that's a good question. It really depends. Because we're going to talk about that in a second regarding your achieving goals and your tolerance for therapy. If they can tolerate it, I'm not worried about the smoking part. No, I am worried about it, and I do get what you're saying, but you can't let that bias get that. Because ideally, I want to be like, of course they're going to stop smoking after this rehab program, right? Because that would be part of one of your goals is smoking cessation. It's very specific, but that would be your call. So, poor cardiopulmonary function. So this is a good kind of bridge towards this part. What does poor cardiopulmonary function do to achieving goals, tolerance for therapy, and benefiting from therapy? What do you think about those three things? What's up?
Makes it more difficult to be able to achieve goals by doing enough work.
Absolutely. Really makes it difficult. So you want to put that caveat in there, because if it takes you a long time to achieve your goals, what is the best setting? In theory. More subacute, because you have a longer period of time. Because remember, acute inpatient rehab, which we didn't talk about, is that it's 3 hours a day, 5 days a week, but you only have about 7, maybe 14 days. It's really a shorter course. With subacute, how long can you stay there? 3 months basically. And it's about 1 to 2 hours a day, and they'll keep you as long as they can justify that you're achieving goals, and then if not, and you can't go home, then you go into the nursing home part of it. And our job as physiatrists is using each of these tools to help you get home, if you can't get home. Okay? So, what do you have here? We have psych, motivation, social issues, energy, cognition, pain, spasticity. The ones in the middle, you want to look at them and make 3 decisions. Are they a positive factor, negative factor, or is it a null? So when would pain be a positive factor?
It's acute.
Acute pain? But so what? What about that pain, that acute pain?
If it's limiting it, so if it's going to be a positive factor, if it's something that can be taken care of in the acute period.
There you go. Absolutely. And this is where your confidence might come in. Sometimes I get overly confident, like, yeah, we got this. Positive factor. But you can see, you're saying, you know what? 10 out of 10 pain. But every time they get their Norco before a therapy session, they do great. They tolerate the therapy session well, which means that their ability to achieve goals, tolerate therapy, and benefiting from therapy is really good. Boom, put in there. When can it be a negative? Chronic pain being one, absolutely. And the converse of what he said, which is,
able to be modified.
yeah, they're like, do not touch me. I don't care what you give me. Gotta go as a negative factor. What about social issues? Because remember, these positive and negative factors are going to help us achieve our goals and then help us make our decision. Okay? So, what about social factors in terms of achieving goals?
Good family support.
Great. So, what does that do to your goals?
You just want to get back into your old life, go back home.
But let me ask you this question. So, when we do our goals, we're gonna put a FIM score to the goals. So, if someone has a new stroke and they're really struggling, but they've got the best family support in the world, what does that do with where you're putting your goals? Can you lower them? Right? You conceivably you could say, you know what, I'm going to put this goal, but you know what? It doesn't matter because they're going to achieve these goals and then they can go home. versus someone who says, I have no social support, and they just had a knee replacement surgery, they're meeting the 60% criteria, you're gonna say, no, we cannot send you home at this level, you have no social support. We have to have you at the moderate level. That's your goals now. So your social factors can play into that. And you can tease it up, saying, wife is going, or sister is gonna take care of all the dressing, and so we can keep that at a supervision level, and then husband is gonna help with the gait, so we can keep that at a supervision level, whatever you wanna do, okay? So what about motivation? When can motivation, because we can say it's a null too. When can motivation being a positive factor, I get, right? I want to go do this, and if I, like, F you guys, leave me alone, negative factor, okay? When is it a null? You get munchkin.
No meaning.
Null meaning you don't put it anywhere, positive or negative. Just say it is what it is.
It's been the same before and after their injury.
No, but we're talking about expand on what you're saying.
Their motivation has changed. It's been
Sure.
they're like kind of okay with things.
Yeah, but most people, to be honest, most people are really, they understand their body, and so their motivation always is appropriate. Some people might have a MS for a long period of time. They're saying, look, this is, I'm independent, I'm cool with it, just leave me alone, I just want to make sure I get my medical treatment, yeah.
Maybe like tied in with psych, like they have like a chronic depression that they've had for a while, and they're just not motivated possibly because that's being untreated.
Great, okay, so maybe you're saying, well then that would go towards a positive. Even though the motivation is low, psych has identified it being a problem, and it's going to be treated, and the patient themselves saying, you know what, the last 2 times I was in the hospital, I didn't do anything, but please give me an opportunity now. So that's a positive. I like that, that's good. When is it a null? This is when it's a null. When they're motivated, okay, and they have poor cardiopulmonary function, and so look, the motivation is there, but it's not going to make a difference in them achieving goals, because what matters most is that cardiopulmonary function that's poor. So you just kind of leave it alone. You don't want to penalize them, because it's not you're penalizing them, but you're already giving a negative factor for the poor cardiopulmonary function. So think about it. You could just say it's not making any impact one way or another, okay? What about energy tolerance for therapy? Who's going to kind of give you the best information regarding that? PTOT. And can you call them?
Yep.
Yes. Call them. Ask them questions. Be super nice so they don't yell at me saying, man, your students are calling me way too much. And then I just put an energetic bowel letter because it's my tread, I can do whatever I want. But as it pertains to short-term goals, and we're talking about home living situation, what is neurogenic? Because we don't always think about it, the disco, I'm talking about the goals. How can neurogenic bowel letter play into your goals?
They can learn how to care for themselves in the acute setting. That could be a goal.
Sure, yeah. What else? When would it be a negative factor?
If socially, if they need help,
Yeah.
but they're not willing to let anyone help them socially,
Absolutely.
like a girlfriend or family member, then it's not comfortable.
Absolutely. Because then we might even say neurogenic bladder at night is a negative factor, which means that their short-term goals may have to be min assist for ambulation, particularly at night. And we just have to call that out to family, just to let them know. Okay. So at the end of this, you're going to go through all this and you're going to stack the deck. Positive, negative factors. Then, what you want to do is, you're going to look at here. This is how they were doing before. This is where they're at now. I've got my positive factors, I've got my negative factors. Now let's create some goals. Our goals are going to be on gait, keep it simple. Gait and all of your ADLs, the PT and OT stuff. So once you've created the goals, and let's say in this instance we said, you know what, I'm really thinking, let's do an example here. Can I write on this board without it clicking? Oh, sweet. Okay.
That's so weird.
Yeah. Okay, so let's say that someone says before, let's give a diagnosis. What diagnosis do we want to do? Give me a diagnosis.
Spinal cord trauma.
Spinal cord trauma, okay? Let's do it as a cervical myelo, okay? Allopathy. Patient says, you know what, I was independent before, I was claiming to be independent before, with a rolling walker, and I can go 100 feet, no falls, and then ADLs were independent, okay? And they say that the gait limitation was secondary to weakness, spasticity, and it was just rapidly declining over the past 6 months. Or a surgeon saw it, says, you know what, we gotta treat this, okay? PTOT assesses them and says, they've had the surgical procedure. We'll just do PT up here. PT says gait is mod A with a rolling walker, and we have pain, and we have, and an OT saying for bathing, we're going to do bathing, dressing, transfer. Bathing, it's going to be at a min A level. Dressing is going to be at a min A level. And transfers, for some reason, it's going to be mod A. Okay? Makes sense? You guys see this so far? I'm looking here. Now I'm going to look at my positive and negative factors. What information do I need to know other than the diagnosis? Comorbid conditions, okay? So comorbids, we can say there's hypertension, there's CHF, and we're at EF of 50%. We get diabetes with peripheral neuropathy, and that's it. Okay? So is there an acute medical issue with an expected recovery? What do you guys think? Our primary diagnosis is a cervical myelopathy.
What's causing it?
What's that?
What's causing
No. It was just worsening. Like you had a slipped disc. It doesn't. Yeah. This is like an acute
It's
process.
not like a tumor. Or...
No. But even so, let's say there was a spinal cord tumor. What do you guys think? Is it an acute medical?
Yeah.
To a certain degree, you can extrapolate it any way you want. It doesn't have to always be. And that's why I want you to think. This is a new spinal cord injury. It's either a 60% rule or it's a acute medical injury. Does that make sense? Okay. So we got a positive factor here. Do we have rehab issues related to the new neurologic process? What do you guys want to know? Could there be? Neurogenic bowel, neurogenic bladder. There's clearly going to be pain issues, which I've identified here a little bit. Right? So we've got two positives here. Psych. What do you guys want to know about this patient?
How is it affecting?
Right? How's this mood? We're going to do a couple of just open-ended case ones, so it makes more sense, right? So if I were to do this, I would say, psych-wise, in this scenario, let's say this patient is psych, there's nothing going on, I didn't call it anything, so I'm just going to leave it alone. Motivation, the patient says, yeah, I want to do this. Social issues, let's say that this patient has family members who are able to provide some semblance of support, so I can say, you know what, we have good social support. They're tolerating therapy well. And their cognition, there's nothing going on. Let's just not even worry about it. Pain and spasticity, pain is there, but they're tolerating therapy sessions well. We've got all this. Negative factors. We've got chronic medical issues, so this is just the CHF. But here's my question to you. Is the CHF really affecting this patient? It doesn't appear to be. I haven't talked about it. Okay, this is a little convoluted here, but we haven't talked about it. It's not as though the PT session said they're half breathing, or the medical notes say they're fluid overloaded, and the list goes on. Okay? So we can even say there's nothing going on here. Now, looking at where they are, what do you want to put for goals here? What do you guys think this patient can achieve in 4 weeks? At the end of 4 weeks, no matter where you send them. You can send them to subacute, acute, home, to Dubai to do a rehab program, it doesn't matter. What goals do you want to do at 4 weeks? Gait-wise, what do you guys want to do? There's no right or wrong answer. How can I prove this is a fake patient?
Walk with.
What's that?
Walk with.
Oh, and fib it for me.
Oh.
Yeah.
So up 1 level 7
What's that?
to 7.
You want to?
6 now, so.
No. It's a modest.
Oh.
He's at here, right here.
Okay, so maybe
He's at a 3.
5.
You want to go 5? You want to go supervision?
Yeah.
I'm fine with that. So let's set our goals for soup. Just at 5. Okay. What about ADLs? He's at a 4, 4, and a 3. What do you want to do as goals wise? And here's the thing. A lot of positive factors. What does that tell you about achieving goals, talent for therapy, and benefit, or achieving goals for that matter?
Likely to happen.
Yeah, it's likely going to happen. You can be a little bit more aggressive if you want to. You want to just put it at a 5? You can. This once again, it's arbitrary. It's a fake patient, right?
6.
You can do 6 if you want to. It doesn't matter. If you really kind of don't have as many positive factors, you can really say, maybe I don't want to be so aggressive with my goals. Now that you've created your goals, these are goals that you're going to achieve. The question becomes, how do you want to use those 4 weeks? What are your options? And what are your options? For where they can do their therapy?
Acute, subacute, or home.
or home, right? Year 3. So where's your tilt table kind of pulling you? Where's this kind of pulling you?
Acute.
A lot more acute. So you know you're going to start off with acute. And how many weeks do you want to send them there for? This arbitrary spinal cord patient.
2 weeks.
2 weeks. And then the question becomes, in 2 weeks you have to think to yourself, where are they going to be? You might even say, you know what, I think in 2 weeks they're going to be here. Fantastic. So I'm going to send them to acute for 2 weeks, and then I'm going to send them home with home health therapy to achieve, maybe get this up to all the WITMADI all across the board. And then long term, where do you want to get them? Independent. Independent. Okay, so let's do another thing patient. Let me just put this up here. Who wants to be a scribe? And you guys can all ask a question regarding my case patient. It's a little confusing, right? A little confusing? Use a sheet, we'll get through it, okay?
Like, how often do you change the fit scores for goals after you like set them?
Every week that you're in rehab, twice a week, you can change those. Yeah, because you want to see if they're achieving the goals.
Right.
Because these positive and negative factors can change. You could have said, oh, pain was actually pretty good, and then all of a sudden you're like, yikes, I failed? We'll go down here. So who wants to be a scribe? Go for it.
I have to get up.
Yes, you can.
I don't want to write down a paper.
Okay, so you get a consult regarding a fake patient, and it's neuro, and neuro says they've had a stroke. What do you want to know? About anything. Remember, we are trying to we have a diagnosis, we want comorbidities, we want social history, we want functional history, current functional status, and then we're going to fill this out, okay? So they had a stroke. So you can just write on this side right there.
So what kind of stroke was this? What kind of physical limitations are we looking at?
Sure. It's a left MCA stroke, right heavy paresis. Exam, I think your question is exam-wise,
Yeah.
kind of a 3 out of 5 on the right side.
Okay.
And what the notes indicate, in this instance, there's some dysarthria and what they've described as mild cognitive deficits.
So here, right?
Oh, you can just write it.
Technically not high or low.
Yeah, just just
Oh,
write,
sorry.
right over here.
Okay, so left MCA. Sorry.
It was right.
Oh, right.
No. Left MCA with the right side of weakness.
Right. Weakness.
And we said it was about a 3 out of 5.
On the right side.
Yeah.
weakness. Okay.
Right. We said a little bit of dysarthria. Which would be just the quality of speech. 1 second. And then we say what it says mild cog deficits.
Mild.
This was written in the chart, so you have to extrapolate here. Okay, what other questions?
For the purposes of rehab,
Yeah.
does it matter for us to know, was it hemorrhagic, ischemic, is that gonna change anything for
No.
us? Okay.
So I think that the important thing is to understand that certain locations of stroke create certain sequelae, but the only thing that you can react to is what's on your plate. So what I mean by that is someone could have image-wise just a pretty impressive stroke, but they're coming at you with a certain level of symptoms. And you only have to address the symptoms or the picture that matters most. Does that make sense? So I'm not, even though looking at the chart is tremendously important about the location of the stroke, it doesn't change what you're examining, what your kind of impression is. Good. Come on. Okay. So patient has diabetes. Uncontrolled. Private hypertension, so. And then hypertension also uncontrolled. They have COPD, which was mild. Obstructive sleep apnea. We'll just put out obesity, so their BMI is 35.
How old is the patient?
Patient is 72. You know what, they'll put down right-handed male. Okay, I'll set yes or no.
Baseline like gait and ADLs.
Got it. Prior to admission, patient used a cane for all distances because of an old right knee arthritis that he never took care of.
Was the cane in his right hand?
Oh, God, he was.
Oh, what's that? Oh, here.
Thanks.
He prefers a cane in his right hand, correct. That was just his style.
Doesn't matter what type of arthritis. Or...
No, just put down arthritis. This is the story that you're gonna get. It was old arthritis, right? So, we know the cane was used right side. No foot drop before all this. Didn't drag his feet. No real gait dysfunction that he describes. It was just straightforward, bad knee using the cane. ADLs were independent. And he reports cognitively, and family corroborates cognition was all good. I should have you guys ask this question, sorry.
Cognition good.
Yeah, cognition good. Alright, what else do I know?
Living situation?
What's that?
Living
What
situation?
would you like to know?
Who does he live with?
Lives with his wife.
But what if that you?
Oh, yeah, just put underneath. Yeah, just put underneath, that's fine. Social.
Where do they live?
They live in Chicago.
Apartment or home?
It's a apartment.
Does he have to take steps to get to the apartment?
You just take 3 steps to enter.
Third floor?
Oh, no, I haven't said that, they haven't asked yet. What floor?
What for?
Second floor. So there's 3 steps to enter the apartment complex, then another flight, so it's a walk up to the second floor, which they say is about 10 steps.
Elevator?
No elevator. Oh, always a good question. No letter of access, but don't forget, it's 3 to enter, so it's 3 plus 10.
Oh, 3.
Yeah.
3 plus 10.
Don't forget about the, how do you know?
That entrance is
Yeah, correct, okay. So lives with wife, second floor apartment with 10 steps, 3 plus 10 steps to enter the actual living situation, no elevator. What else do you want to know?
Employment or retired?
Retired.
Any steps within the actual apartment?
No.
And is the wife able to care for him upon going home? Like, does she have any comorbidities
Got it.
herself, or?
Wife says she can help with anything that involves him sitting down. So she can help with the ADLs part, but if you were to walk and had to provide physical assist or physical assist with transfer, she cannot do it. And she's very bright, so she can be a coach more than anything.
What was his previous job?
He was a factory worker.
Education.
He finished high school.
Any other friends, family willing to help out or able to help out?
Sure. The son lives on the first floor. Jerk, doesn't give his parents a first floor apartment. And their daughter lives on the third floor.
But they don't have them. They don't.
Oh, you didn't ask it that way.
Oh,
Can they have-
are they willing to help or
The-
were
the
they
son-
part of the team?
Yes, the son and daughter would like to be able to provide help.
Son on the first floor, daughter on the third floor.
And then any substance use or abuse?
No,
good
no
question.
illicits. Anything else?
Takes his meds regularly?
What's that?
Does he take his medications
Good
regularly?
question.
Probably not.
The medications he was told to take, he took. So that's another thing we should be careful of. We don't want to typecast somebody. It's a very good point. Sometimes, if we don't do a great job of explaining to somebody the importance of taking your hypertension diabetes meds, or I even happened to a couple of my patients, I gave them their refill of one of their meds, and they came back 3 months later. I'm like, what happened? They're like, oh, I took it for a month, and then it stopped. So I stopped the medication. I didn't know I was supposed to continue. So I didn't do a great job of explaining to them, this is important for you to, it's a continuous kind of situation. Because it honestly makes sense. Like, you have a problem, you give you a month of something, if you, it should get fixed. I don't know if this is a continual problem, right? So, so if given the right instruction, he'll take his meds. So this was all doctor's faults, diabetes and hypertension. This, a lot of times.
What would you write that?
Huh?
What would you say for that?
No, I would just say that he's a compliant person.
Compliant
compliant,
person,
yeah.
but lack of insight?
No, and we can't call that out yet. It's a very slippery slope. Because health literacy is not, you can't.
It's not their fault.
Yeah.
All the time.
Right, exactly. And what I would say is that the patient's compliant, but if you're saying, if you feel like there's a health literacy perspective, you have to find a very respectful way of, you don't necessarily document it, but you should be more conscious when you speak to the patient,
Okay.
okay?
Would I put that here? Compliant patient.
Yeah, you could, wherever you want to put it, that's fine. You can put the OA as well, the right knee OA.
Oh, right.
And see, the purpose is that even though the comorbidities are listed which way, when you talk about their functional history, they start talking about other stuff that's happening. If you
Find out more later.
Yeah, exactly. What else do you want to know?
Does he drive? Or he or
Yes.
she?
Yeah, I said he drives, yes, he drives.
Okay.
Yeah, you can put it here, it's fine.
It's okay.
Yeah, we're all paying attention, yeah. He's driving.
Try.
But, what's the question you should ask? Yeah, he was driving.
Any difficulty?
Is that difficulty?
Getting in and out of the car?
Car, you know, the question I would ask is,
Can you see?
no, no,
Right.
is your family okay with you driving?
Oh, okay.
Family was not okay with him driving because of visual issues.
Oh.
Yeah.
So, what visual problems?
Which points to the fact that he has diabetes. What does diabetes do? Affects every part of your body. So you might have diabetic retinopathy. Want to be mindful of visual spatial deficits as we create goals if he's kind of everything, right? You know who's going to help you with that? Peachy's going to do it. Nochi's going to help a lot with visual spatial stuff. So they're going to tell you, is it a neglect or is it, simple visual acuity? At least a starting point. What else do I know?
How active was he before all of this?
Awesome. Not very. Good. But he could, and the question we forgot to ask is, he would walk all distances. He could walk, the question is asked, how many blocks can he walk? So he could walk about 5 blocks. And then what do you want to know?
Why does he stop?
Because of his knee pain. And that's why he was sedentary.
Did he used to get around his apartment on his own just fine?
Yes. Inside the house is fine. Just he was good about using the cane. It's just commuting distances of 5 blocks. I mean, if you want to get really specific, then you have a true city block or a small city block. Because my brother lives this long block away. So your block, I'm like 3. It's like 3 city blocks. What else do you want to know?
How's his mood before and after?
Mood? No mood issues.
No, before.
Any pain, any spasticity right now? Or like after post-stroke?
Post-stroke, and we'll get to that in a second. Yeah, we'll get to it in a second. I just want to do just the prior level.
Any psych history?
No psych history.
Any problems with bowel or bladder
Before?
prior to coming in?
No. Great. Can you incorporate those rehab issues pre? So you can ask that question, pain and spasticity, we know that pain was a knee issue, but no spasticity. Great. Remember, rehab issues, bowel, bladder, skin, speech, pain, psych, cog.
What was he taking for his knee pain?
He was taking just Tylenol before.
Do we want to put meds on here? Because meds can affect function.
Yeah, sure. You can put on, you can go over here.
Was the Tylenol controlling his pain?
No. But he's a conscientious person, doesn't want to get crazy with the opiates.
Well,
You said he denies any fall?
Yeah, no falls. I don't think we asked that question. No falls.
Okay.
no falls at the time it happened?
No falls. Prior level of function, there's no history of falls
No
despite his
history
gait
of
dysfunction.
What meds does he take?
I just tell him, that's all he's doing. Yeah.
None of this stuff?
No, this is why he's
Oh dear.
found himself in the hospital. So,
Does he smoke?
no smoking? I think we said no illicits. Yeah, no illicits. Sorry if I think we just.
No substance abuse,
Yeah.
so.
Is there anything else? Do you want to move on to the next section?
How motivated is he? It's getting better. Can you ask that now?
Yeah, no, just
Mine's
wait.
on that
Yeah, just
point.
wait. You really want to separate what was prior and
Okay.
what's going forward.
Now.
Prior, and we know the kind of the basics of what's happening here. Okay. Now, when you look into the medical chart, what do you want to know about the comorbidity here? Because that plays into the current.
Yeah, what stage he was in for everything.
For the current functional status, can I move this over? That's fine. For the current functional status, you also want to know what the medical status is as well. Okay, so what do you want to know about the medical status here?
Does he follow up with a PCP for all these issues?
Oh, no, I meant acutely in the hospital.
Oh, okay.
What do you want to know?
It's glucose and ailments.
Yeah, or I guess, let me just kind of frame it a little better. With the diabetes, they got it under control right now, at least in the short term. The A1C is not more reflected. So we can say that since he's in the hospital, the internal medicine doctors and the endocrinologists have the blood pressure under better control and the diabetes under control. But they've done a echo as part of the stroke workup, as an ischemic stroke, and they discovered that his EF is 40.
40?
Yeah, 40%. Not great, not bad, but mindful of this. And then the diabetes doctors write down that he's got peripheral neuropathy, or at least had described it to them, and he's got diabetic retinopathy, which we've kind of got a little bit of a clue here. And the stroke workup is going great. The neurologist said, be careful with the blood pressure meds, don't get crazy, because if you do, if you break your permissive hypertension too quickly, the blood won't be perfused and will unmask worsening stroke symptoms. So please, he's doing fine at 160 blood pressure now. But it's fine, it's under control, so it's fine. It's just permissive hypertension. Okay, so that's what's happening medically right now that's new. Now, what do you want to know about his current functional status? What do you want to know from PT?
Gait, how far he's able to walk, what the thin score is in terms of gait.
Good, great. We'll say that his PT note says, fin-wise, and you can ask more questions about what PT said, is that he's at a modest assist level, so it's a 3. Let's just do the scores. So it's at a 3. And he's using a rolling walker. But he's, of course, requiring modest assist, so it's... And, of course, the right-sided weakness is present, that's fine. He's got a fair amount of pain in his right knee. That's the initial line. What else? What other questions do you want to know?
Is that knee pain the same for, like the amount of pain was it before the same amount?
It's kind of subjective. What do you really want to know about that pain?
Is it limited?
It is not limiting therapy session. It's present, but it's not overwhelming therapy session. Could it get better? Sure.
How far is he able to walk at mod A?
Oh, great. He can do about 10 feet.
How is tolerating the sessions?
Good question. He did all 45 minutes of that session with PT. No missed minutes. They'll always look at that missed minute section. What else? Is there anything else, Wendell? We can always come back to it as we may. Let's go to OT.
But-
Okay. Oh, no, go ahead.
go ahead, yeah.
Let's do OT. So what do you want to know about OT?
Eating.
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 Yes, he can feed himself with his left hand. So he's a 7. 7 on eating.
7.
Dressing and bathing.
Dressing is a 3. Is it 3 for upper body? And 3 for lower body. And bathing, you said, is a 2. Max assist.
What about talking? Is that,
Speech. I guess the question becomes, no, expand on that. Because we talked about
you get to
mild cognitive deficits, right? So what do you want to ask PT and OT, or do you want to ask OT?
I'm a messy.
You can, but you can ask a very simple question. You don't need to waste time.
Could he follow like a 2-step?
Yeah. How's he engaged? How's he doing cognitively? He's doing well. He's got some concentration deficits, but he's carrying over. He's participating. He's demonstrating insight into his deficits and his ability to carry over. So really, if I were to say, is that a positive factor?
Yeah.
Yes. For foreshadowing for the future. But
I'll have
okay.
it right there.
No, yeah, don't worry about it. Don't worry about it. Now, let's do our positive and negatives here. What do you want to do, positives and negatives wise?
Sorry.
No, it's all right. So positive factors, is there an acute medical issues with expected recovery or 60% diagnosis?
Yes.
Yes. Here's the thing, you can weigh this any way you want. If you think that's the most profound thing, you can put, 100 pluses, because it's a stroke, right? So you can put any way you want. Okay. Rehab issues related to new neurologic process. There's neurogenic bile, I would assume. There's some cognitive issues. There's some pain issues, which could be spasticity. So we got that? I would say so. Do we have any negative factors here? Is it poor cardiopulmonary function? Is it is it really bad cardiopulmonary function, or is it just no?
It's
No, I would say it's no. Yeah. Is it no? Let's see.
Dr. Kasi, quick question. So his peripheral neuropathy and diabetic retinopathy, would that count as a negative factor because of the kind of chronic conditions that aren't really able?
I would say, and it counts in this way, it's gonna shape your goals. It's gonna, if he's got these bad visual spatial deficits, it's gonna be harder for him to achieve that mod level, or maybe even that supervision level, where he might need assist to kind of set up things or guide his hand. So, yeah, I would say chronic medical issues. I would say the peripheral neuropathy plus the diabetic retinopathy, absolutely. Because remember, what is the first thing we're gonna do before we do disposition? What's the first thing we have to address after we do our positive negatives? Set our goals, right? So anything you say, absolutely, I agree with you, that's a negative factor. So,
Obesity,
obesity, which way do you wanna put it?
gonna be
And you might, I could even say, here's my argument. I could say it's, whatever it is, it's 35. The question is the obesity playing into the therapy sessions? Therapists could say, no, it's not. Patient's got enough strength, they're managing, it's not an issue. Or it could go that way. So usually if it's, really bad, but regardless, it's fine. So what else? Okay, psych. What do we say? There's nothing going on, is it a null? You can ask, the best person to ask, look at that therapist note, because I'll say, horribly depressed right now, but it was not an issue. Motivation. Social issues. Positive, right?
well, he doesn't have a lot of support.
Oh no, the scenario was that he has 24-hour, like the son, and the question is, will the son allow dad to live on the first floor? Yes. So it really says now your goals, they're not 13 stairs, they're 3 stairs.
Yeah.
So social factors, we got tolerance for therapy, yes,
Yes.
he tolerated the whole session. Cognition, it's positive here. Pain and spasticity, what do you guys think?
Positive. We can get it.
No, make the argument for positive.
Well,
Because it affected him, but what could you do with that knee pain?
he's had it for a long time. He's
Yeah.
on Tylenol. We could add to that or
Yeah.
figure it out.
Yeah, absolutely. And if he doesn't want payment, what can we do? Inject it, right? That's all you do is inject, right? And then neurogenic being we talked about. So we've got quite a few number of positive factors. We got some negative factors, very important. Now, you want to do goals?
Sure.
Okay, so what goals do you guys want to do? Short-term goals in 4 weeks, with us understanding this. Think about this. We've got our medical condition, comorbids, the prior level of function, the social situation, what's happening now, and now we know our positive and negative factors. So what goals do you guys want to do? Do gait. What do you guys do? What do you guys think gait-wise would happen? In 4 weeks, no matter where they go.
3 steps.
Well, he's already doing 10, right?
And each needs like 3
No,
stairs.
3 stairs.
Oh,
sorry.
3 stairs, yes. Now the question becomes, at what level do you guys want to do that?
What do you mean?
Oh, what's the thin score?
Oh,
We would like it at supervision, that way he can go home, but I don't know if that's gonna be capable with
Sure.
so maybe meniscus in 4 weeks.
And
Supervision would be like
Yeah.
realistically the goal, but I don't know necessarily if that would be capable with some of his comorbids.
And you know what? You bring up a very nice point. That's the major dilemma. Are my goals realistic versus are they what they need to do? There's no answer to that. And don't feel bad about that. Because that's where people will disagree. I'll say, what are you talking about? They can't do supervision. He's already struggling so much. Whatever. Set your goals that you think are realistic. You want to do meniscus? We'll do meniscus for
Let's
stairs.
do meniscus.
Okay, meniscus for stairs.
My question about that
But
is,
just put over here into the short-term goals.
my question about that is, his wife won't help him with that.
Sure.
Will they be capable, his son and daughter? Do we have to assess them too?
Yeah. Well, not you have to assess him, but the son says, son's a bodybuilder. He's good,
Okay.
right? So he can provide that meniscus. Because good, you want to know who's going to provide the meniscus after 4 weeks.
I have a question. If you live in your own home, like obviously you can put in a ramp, but if you live in an apartment building with other people,
Yeah.
is that something that people, like, can you have a ramp put into an apartment building?
You have to ask for permission. It depends on who owns the building.
Okay.
And, I shouldn't be eating an natural bush, I'm sorry. It depends on where the staircase is coming, because there's city laws that come into place as well. So it can get a little bit difficult, so.
So don't count on that.
No, don't count it. And also the finance part. Unfortunately for me, the far majority of our patients can't snap our fingers and get a ramp.
Yeah.
So we have to do meniscus for stairs. What else? What about gait? What do you guys want to do with gait wise?
20 steps. 10, 20.
What M score?
So he's walking 10 feet. I guess I didn't miss this, but with therapist. Oh, with a rolling walker. So with a cane.
Do the fib. The fib will be easier. He's at a fib of a 3. Modest this. What do you guys want to do? 4. Not a big deal. There's nothing wrong with what your goals are, right? You make the argument any way you want. So 4, walker, ideally it should be 150 feet based off of what our, did we do the FIG lecture? A little bit?
So I was.
Yeah, that's right, 150 feet.
150 feet?
Yeah.
So a number corresponds to, okay,
FIM score, you would have to walk the 150 feet to qualify.
for a 4.
Yeah, for a 4.
Okay.
In theory.
Okay.
Okay, what about ADLs?
So eating, he's already at 7, so we
Already
don't
at 7.
need to worry about that.
You wanna go to 8?
Dressing, maybe a 4, or
Sure.
just like a setup, if that's gonna be his
Fantastic.
thing right now.
Why don't we just put them at a 5?
5.
Yeah.
Why don't we care about, I guess we don't have so much time, but we don't wanna bring the eating up to me, depends on how
No,
much.
there's no
we
way,
have.
7 is highest.
Oh, yeah.
Yeah, so you're fine, yeah.
I wasn't thinking.
And bathing, what do you wanna do?
3, maybe 4.
Fine, whatever. Just set the goal. You guys get to it. Doesn't matter. I'm not trying to dismiss it, but that's how arbitrary it is, right? It's my opinion versus yours. Okay, great. So I'm gonna use it now. So in 4 weeks, we want to achieve those goals. I think that's reasonable. Now the question becomes, how do we get there? So now let's look at our piece of paper. Which way are we turning? Acute. Fairly obvious, okay? So in 4 weeks' time, so my question is this, and this is where it gets tricky. How many weeks do you want him to be in rehab? And pick something arbitrary. So 2 weeks, okay? In 2 weeks' time, he will achieve something. In theory, it takes him 4 weeks to get there. He might actually achieve all these in that acute rehab setting. Let's say that this family is super engaged. So after 2 weeks, where is he going? Home, and we'll continue to work on really solidifying these short-term goals, either with home health therapy or outpatient. Let's say that he gets close to these goals in 2 weeks, but family says, oh, you know what, I really want to take back everything that I said. So after he goes to acute for 2 weeks, for him to solidify the goals, where can he go? He can then transition to subacute if needed. And we're doing this on the fly. Does that make sense? And then of course, long-term goals, you can set something different. You can just say supervision across the board, which you can do in a different setting. Which when they come back to clinic, you can kind of do that. Okay? Now, the caveat will be, let's say you do all of this, okay, and the patient's at a supervision level, and the therapist, you call the therapist, like, my God, every session, they're just kicking butt. They're just achieving these goals. You have a tremendous number of positive factors. Let's say that you know that they're going to achieve these short-term goals in about 2 more sessions. Where are you tilting then? No. I'm saying is in the when you're doing the consult. When you're doing the consult, you're looking at therapy notes, just saying in 2 more sessions, they're going to actually achieve their short-term goals. Of money. What's that? So where are you tilting?
To home.
To home. Does that make sense? So if they're rapidly achieving their goals, and these goals are goals that we know that they can achieve in 4 weeks or get home, then you can actually go home. That's where that tilt goes to the right side. So let's solidify this. I got cases. You guys can get your groups of. Go ahead.
So when you're making these goals,
Yes.
do you play into like what the patient's goals are too?
Absolutely.
Right.
You always ask them that question, but a lot of times acutely after a stroke, they're going to say, it's the more about dramatic. I want to walk in.
But for like a different example, like, I mean, is it just like kind of objective what you think they're going to be able to do, or do you like play in, they want to be walking like
Sure.
independently again, and I think I would probably put them at a FIM 6,
Sure.
but like they want to be a FIM 7, so we're going to try that, or
No. So there's 2 different things. One, you never want to focus on goals that don't matter to a patient. So if someone's got primary progressive MS, you can't put your goals as being ambulatory. The patient might say, look, what's most important for me before I go home is for me to solidify my transfers. My strength isn't going to change, but this is more important. Don't waste your time with anything else. We'll go to the subacute for a week and that's all I want to work on. Fine. If that same patient says, I want to start walking again, now you need to have that conversation with the patient and saying, these are your actual realistic goals. This is where I can get you. So you have to understand what their goals are, but make sure they are realistic goals. But it's a conversation, because if you don't have that conversation about your short-term goals, how much time it's going to take, and why, you're really going to lose that patient for achieving. So let's do this into groups of. We have 4 groups. You do 4 groups. You can do You can do 4 there, 1 here, and then, or 3 of you, 3 and 3. So here, do this case. Yeah. What you guys do?
Use the donuts.
Upside down. Oh no, here I got more. Oh, you got case. What is it? 1?
Case 1.
All right, 1.
Your case 2.
References on my deposit.
Just look at this real quick.
Yeah.
You're giving case 2.
Your case
1.
Hi.
You want to put it in?
What year?
Good case 3.
Starting at what?
Oh, here's another case.
And it wasn't very
Here's
long.
case 4. So if you get a scratch piece of paper and just, I mean, whatever, but go through the whole progression. You guys got it.
I guess, okay. My handwriting is that good.
Just the best I've ever seen.
Alright.
So each of the cases end up having a different, not all of them, so let's go over the first one. Do you have the AD case?
We did.
Okay, so what are your general impressions, just so everyone knows? What I can do is I can email you guys different cases so you can kind of look at it and go over it next one. So what was the kind of general consensus about the pre-morbid kind of functional?
Okay, so we had a 52-year-old female coming in, past medical history, hypertension, anemia, GERD, seizure. But the biggest thing was a previous stroke in 2014. This resulted in left side weakness, spasticity, pain, kind of your whole normal stroke symptoms. And she's on a whole host of things. Oh, and what she's coming in for, I'm sorry. She's coming in for with an acute headache. And so the way that she's describing it is more severe than her previous headache. But there's no real change in her functional capabilities. It's more so just her headache that's causing her an admission primarily for the headache. So previously what she was on, a ton of stuff for her spasticity, her pain. So baclofen, gabapentin, Norco, Furoset, things like that, left shoulder sling. And then she, again, the comorbid conditions, hypertension, hyperlipidemia, the CDA, seizure, things of the sort.
So I guess, yeah, so with the functional history, she's kind of limited at this, she's kind of walks with the walker, with the or with the cane.
Yeah, well, so she walks the walker in the house, but all community distances is going to be in her wheelchair. She said she can ambulate 25 to 50 feet in the house, but she's limited secondary to her pain and fatigue. No foot drag, but she does have a scissoring gait. ADLs that she needs assist of her husband due to her left-sided weakness and pain. And it would take a long period of time if she didn't have an assist. She bathes 3 days a week because she needs extra assistance during bathing. COG, the husband's noting a slight decrease in COG because she's having word-finding difficulties, also kind of forgetting if she took her medications or not, things like that. Other than that, everything's pretty alright. Her living assessment, she's got 12 steps to enter with her husband, which he does to assist. Family support's available.
Yeah, so if you look at the case, this patient had a old stroke.
Yeah.
One-sided weakness, kind of in this in-between, she's technically independent, but needs a lot of assisting, doesn't do a lot of things, came in with headaches. So in your opinion, looking at the FIB scores and looking at, and so if you say she was independent, but the FIB scores were all what? More of a,
Fours.
yeah, more of a mid-assist kind of across the board.
She did need match assist for lower body dressing, and then she was supervision or set up with grooming and upper body dressing, things like that. But all other kinds of gait, things like that, rolling in the bed, sit to stands, things like that, those were all mid-assist.
And so looking at it, in terms of comparing the prior level of function to the current functional status, was there a change?
No, it was about the same.
It was about the same. So now when you look at it here, what are your positive and negative factors? Which ones do you actually want to throw? Like not throw, but which ones are kind of actually impacting your ability to achieve goals or anything?
Yeah, and so for us, one thing that we were thinking about is that some of the things like that we consider positive factors, family support, things like that, they're going to be limited in this regard because we don't really see that there's going to be much change in her functional status here.
Correct.
The only thing, even though she does have family support as a positive, there's an inherent negative here in that her daughter is pregnant, so and she's about to give birth to a baby, so upon discharge, she's not going to have that help, and then her husband has 12-hour days, and so she's going to be home alone for an extended period of time during the day.
So I guess my question to you is that now are you just basically you're stacking more negative factors?
Yeah, even though it says yes, support is available, but upon acutely coming out of the hospital upon discharge, she's really not going to have as much support as she did prior to coming in.
Okay. Now, in terms of short-term goals, it seems to me the only thing that I'm seeing in terms of where you want to throw anything, I haven't seen any positive factors. I see that a lot of no. I see a lot of negative factors. Chronic medical issues, poor cardiopulmonary function. Do we have goals that we can actually achieve, or is it more of a maintenance or a fine-tuning, so to speak, or nothing?
And that's kind of what we were all discussing. It's like, hey, she's got a 3-year-old stroke. What are we really going to do in terms of gains is probably not going to be very much. Can we teach her different techniques that would limit the amount of assist she needs, in whether it's like lower body dressing or bathing and things like that? And we think that that might be possible. So what we do there in terms of going towards subacute versus home, it depends on like how much support she can get at home, because that support at home is kind of limited. We were curious whether subacute is a good idea.
And so basically what happens is with the social factors here, the social factors here are going to demonstrate how many goals you actually need to achieve. So let's say that all these people come out of the woodworks and your short-term goals are the same as their current functional status. Then where do you go? Oh, let's say all of a sudden the social people that are providing support are saying, you know what, we can't provide that support anymore. We probably want her to do dressing or bathing a little bit better or improve her endurance. Now that negative factors, where is it going to be? Here. So it's that social factors where you put it. And so in the social factor, in this instance, my personal impression of this patient was that the social factors are there's too many negatives now. The pregnant daughter, the husband that's working a lot, the fact that she's still coming into the hospital fairly frequently, I'm pulling it more into subacute. Now, if she says, you know what, everything's the same, we're going to make it managed, there's going to be some family friend that's going to come, there's no new goals that we need to achieve, with home health or outpatient therapy, home maintenance therapy. Does that make sense?
Yep.
Okay.
One of the large things that pulled us to more subacute too was that you mentioned that when support isn't there, they have her in a diaper to go to the bathroom. And so we wanted to try to make her more functionally independent and safe so that we can do transfers and whatnot. So
Absolutely. And this patient is a patient from my clinic, so she has a lot more independence. It's just a rough patch right now. So cool. Group 2, what do you guys have?
So we had a 67-year-old female, and she had comorbidities of hyperlipidemia and tobacco smoking, which she had been doing for 20 years and quit a year ago. But other than that, no other comorbidities. She had a STEMI, a type A dissection, and had surgery for it about a week ago. And prior to her STEMI and dissection, she was able to walk and ambulate, had no limitations, no cognitive deficits, and was able to walk community and household distances. So nothing going on beforehand. But after the STEMI, she was under the care of many consults, and she currently, a week later, has a small acute cerebral infarcts. She had some lower extremity paralysis, elevated LFTs, small bilateral pleural effusions, urinary retention, and she was on a bunch of meds. Otherwise she's doing well, otherwise.
Got it. So she was independent before all this heart attack, and then came in here, and if you see here, she had the new stroke, obviously all the cardiopulmonary stuff, which is acute or chronic. Maybe we talked about the CHF part. It's more acute, right? So it's acute stuff. Do we feel like we can make a difference?
Yes,
Or
because,
with the cardiovascular surgeons?
right, yeah.
So functionally, how's she doing now?
So she's, so her FIM scores, were.
You can look up on the board.
Oh, okay,
Yeah.
I can't read.
Oh.
There's all 3 to 4s.
Yeah, they're
Yes.
3 to 4.
Yeah, 3 to 4s.
There's some zeros, 1s and 2s for upper and lower body dressing, and toileting
Sure.
because of her her bladder urinary retention.
Sure.
But other than that, she's doing, her scores are 3, 4, some 5s, her cognition to 7. So we feel like we could get her up to, 1 or 2 points up. She has a lot of family support.
Yeah, your positives were what?
The fact that it's acute.
Yeah.
And it's fixable within an acute setting.
Yeah, like there's interventions that are gonna make a difference for her if she falls. What other things did you put up to, positives?
The fact that she has family
Yeah.
support.
Sure. Yeah, absolutely.
They can move to the first floor.
Sure.
Which is 7 steps. The new neurological process, so she's an acute infarct.
Sure.
Which doesn't seem to be affecting her too much otherwise, but she has a lower extremity paralysis
Yeah.
that we work on. She doesn't really fit in this, I was kind of confused about her being part of the 60% rule because it doesn't really happen.
In theory, you could count it, but
Okay,
in theory, you could count it, but in a truer sense, the stroke is not really providing, it's really not,
the STEMI,
yeah, it's just, the STEMI is the biggest problem here.
right,
But it's still,
it still counts,
yeah, it's still, no, it's not a 60%er, but it's an acute medical
Oh,
issue
yeah.
where we had an expected recovery.
Right.
So, yeah, it would definitely be a big positive. Were there any big negative factors that were just kind of drawing you away?
not really, she's motivated, she's, doing well psychologically, her social issues are, everything is in her favor in terms of socially. PT, OT, you're saying her energy's okay,
Good.
Doing well, cognition's a 7,
And that's a positive, right?
yeah, these
Despite
are all
the
positives, yeah, and then the only thing is she has a bladder, urinary retention, which we could fix, and then the pain wasn't
No,
really.
you don't want to say fix, but something we need to address. Yeah.
Yeah, we would be addressing that, that's the only thing that was significantly, impairing her. And then the pain wasn't really commented on here, so, but she's under meds and it sounds like it's under control.
Yeah,
based on
it's a no. We don't even worry about it.
Okay,
Short-term goals, what did you guys put down?
to get her FIM scores up like 1 or 2, maybe 2, even for.
Yeah, just want to do supervision across the board.
Yeah.
Gait and ADLs, just a generic, good enough. Then where were you kind of tilting?
So towards acute,
Acute.
yeah.
So how many weeks did you want an acute for this patient?
We wanna give her a good 4, just.
Sure, you can, as long as you achieve those goals, right? You can say 3 weeks and then home, whatever, 3 weeks or whatever. So cool. All right, what'd you guys have?
Okay, so we had a 63-year-old female patient with a past medical history of NASH cirrhosis, cataplastic large cell lymphoma, morbid obesity, Hashimoto's thyroiditis. She's now, she now had a liver transplant done. Regarding her comorbid conditions, her neuro exam, she's taking tramadol for pain, her CV, most of her conditions seem stable, so
Sure.
we didn't want to dive into them too much.
Right, and here's the thing. See what the PTOT note said?
Right.
Might just be a no. It's there. We're gonna think about it. Maybe in a couple of weeks it'll be an issue.
Exactly.
Okay.
Yeah, so prior to admission, the patient's gait was in steady decline. This was mostly due to the hepatic encephalopathy she was having because of her liver problems. Regarding, ambulation around the house, she had poor ambulation around the house, poor balance and a history of falls.
Sure.
ADLs were variable.
And in that instance, she talks about ascites,
Oh yeah.
pulling her down, the weight of the legs being swollen,
Yeah.
and then of course just energy, fatigue, fluid overload in the lungs, and then so there's this kind of course that you've hopefully addressed with this liver transplant.
Right, yeah. So regarding ADLs, it was variable performance. Some days she would require assist, some days she wouldn't. But most of her issues were due to like just being tired generally.
Sure.
Cognition, days leading up to admission there, it was pretty intact. But before she did have hepatic encephalopathy, cognition was variable. You want me to go through some of this?
No. And socially, she's got good support or bad support?
Good support.
Good support.
Right.
And the reason why it's not that I'm dismissing the
Yeah.
subtleties of the social issue that you got. You want to be kind of on your rotation. They're not going to be like letting you talk that much.
Okay.
Yeah, you'll find that sweet spot of details and lack of
Okay,
detail.
sure,
But
yeah.
you're fine.
Yeah.
And so here's the thing: it's either good or bad.
Right.
And if it's in between, then you're say you're going to tweak your goals.
Okay.
Functionally, she's doing what right now?
So most,
Yeah, it's up at the board. Hey, go ahead.
yeah, so mostly for most activities it's moderate assist,
Sure.
moderate assist, or total assist. So she's kind of not doing as hot as we would like her to be doing.
Yeah, I mean, she's got things
Yeah,
she needs
a
to
lot of
do
things
better,
to do.
right? And then look at her pain scores there. You can see pain scores are 6. So something that you want to say maybe a positive factor in
Yeah,
this case.
positive factor, so maybe we can help manage that.
Yeah.
acutely.
Just,
Yeah.
you know, sliced open her abdomen here, right? OT wise, where was she at?
So she was pretty much at 5s and 1s, so 5 for eating.
Yeah.
And then 1s for like everything else.
Sure.
So cognitive skills, she's cognitively intact,
Okay.
alert and oriented. We kind of talked about.
So here's my question.
Yeah.
Positive, negative wise, where are you putting your positive factors or negative factors here?
So for most of the issues we've talked about, we put them in the positive category,
Yeah.
just because they can be acutely managed or held in acute care.
Yeah. And even the pain is there, we haven't have evidence to show that's a tremendous negative factor towards achieving goals. It could, you could say, yeah, it's big, you know. So she's kind of at this modest level. Where do you want to set your goals at 4 weeks from now?
So for gait, we said like maybe like 5.
Yeah.
5. Stairs about like 3.
Okay.
Eating 7.
Yeah.
Dressing about 3 upper and lower dressing.
And I would even look at it this way: it was a liver transplant. There's not a new stroke.
Yeah.
So without a neurologic deficit, the likelihood of them achieving these more dramatic FIB score changes is there. Versus a stroke, it's going to be slow and steady.
Slower, yeah.
I just put it supervision across the board, even mild across the board.
Okay.
Unless the pain is so horrific with the abdomen that we're saying, hey, maybe min-assist for the dressing because she's got a viral core to get those. All right.
Okay.
So we got a lot of, we just say, and it doesn't matter. This is it's an arbitrary.
Right, yeah, for
I know the patient, which is why I'm like,
Okay.
get this information. So short-term goals are there. Which way are we kind of leading? What do you want to? How do you want to get there? Acute
Yeah.
rehab. How many weeks?
4
4 weeks. And
or maybe less.
yeah, just usually 4 is pretty advanced. That's more for the neuro-based ones.
Okay.
This one might even be 2 weeks,
Okay.
and then she'll achieve those goals to help her get home.
Yeah.
Does that make sense?
Yeah, for sure.
And the last one, what did you guys see?
So we have our 61-year-old male with a history of hypertension, hyperlipidemia, TIA, who came in for a subdural hemorrhage, and he was found to have an occlusion of the carotid. He got a CEA, he's doing well. Before, he was really, really independent, didn't really need any support, was operating cranes, working. His PT assessment was so good that PT signed off automatically. He's had 6s and 7s. OT, kind of same story. There was some issues with transfers though. So our overall assessment was that he has a lot of positive factors. He is essentially already at a maintenance level with like some very specific things that need tweaking. So we were feeling pretty confident that he'd be able to go home with some outpatient therapy.
Fantastic. And you still have goals, all right? So in this instance, it was eye, and then you had some deficits with, was it cog? There's some cog stuff there?
Yeah, but like
Yeah.
questions on if it was just language barriers.
Sure.
He just had a really cute
Awesome.
brain event,
Yeah.
so maybe his English isn't as acute as it would be after like recovering for a while. So there's cultural things.
Absolutely, and that's a very good thing. You do not want to typecast someone that's having cog deficits because they don't speak the same language as you. And then you had mentioned something about transfers, right? So close to our previous level, and then a lot of positive factors, but these goals are basically the same as his current level because he's independent. So we have our short-term goals are basically maybe work on transfers, maybe check a cog evaluation a couple of months down the road, or just telling family, let me know if there's a cog issue, but just go on home, okay? So when you guys go to your rehab, and I'll email you the rest of the other packets that anyone else does so you get an appreciation of different cases, try to use
this chart if you like, and really try to put together a case. Try to make an argument of what you think. Do not feel bad when you get overruled. Just ask like, hey, where did I go wrong? Because where you typically will go wrong is that maybe your goals were too aggressive, or their impression of, let's say, that pain is they're saying it's a negative factor. No. And you're saying, no, but I saw them in therapy, or the therapist said they can actually tolerate it. They might say, whatever. It's where you weigh it, is where you weigh it. And you can, let's say you have a whole bunch of negative factors here, but it's a spinal cord injury. And you're saying, to me, that weighs a lot more than all the negatives. You can weigh this any way you want. Don't get overwhelmed with the number of positive negatives. Just weight it any way you want. Okay? You guys have any questions? Okay. We'll do the next meeting will be, what date will be? July something? July 8th?
Yeah.
Is that fine? Because it's right after July. The 4th one is fine. Okay. Yeah, if you guys have any, we'll just kind of focus more on what's happening in your audition electives. If you have questions, just let us know. It'll probably be like 1 week in. And are you guys doing anything in June for audition electives or no? Oh, what is step 2?
In a couple weeks.
7 days.
Oh, 10 days?
Yeah.
Oh my god. Oh. So yeah, that's fine. No. Study for that. Whoever comes to Rush, I'll get the curriculum to you guys as soon as possible for the Rush one, so you guys can read if you're interested. But it's about this.
Also, so in terms of people who go to Rush Hour Park, things like that, will we find out prior to getting here, or?
No, it's still, this is being done on the fly.
Okay.
So, but I still need to make sure that if someone goes to Rush Hour Park, well, one, if you go to Rush Hour Park, you'll come to Rush first, and then we'll make sure we kind of usher you in different locations. And I also want to make it fair. If someone's like really like, no, I just don't want to, I want to respect that.
Yeah.
Not that I would, either way, I want you to feel comfortable. But then and Max is one of our faculty there, so he'll do a great job teaching. I just want to make sure he knows what the curriculum is. So I got to solidify all of it. So don't worry about it. I'll take care of it. And whatever you want, we'll do for you. So. Any other questions? Okay, go to the races. The Disability Pride Parade is July something. You were there last year, right?
Yeah, I'm gonna go again.
Yeah. So sign up. The email got sent to you guys, I think.
Yeah.
Yeah. So sign up for it if you're interested. It's just fun. You get to walk around State Street this year. So yeah. And we'll.
Everyone's like having a good time.
Yeah. It's super chill. So all right. We'll see you guys next week or next month. So.
Thank you.